Hello, everyone. Thank you for joining us for today, and thank you for having me. I'll be talking today about CNS infection. So let's start it. My name is Jihad, and I'm one of the neurology trainee in Derryford Hospital. So brain is obviously can be affected by infection as any part of our bodies, and this can range from bacteria to virus, fungi, or even parasite. And CNS infection sometimes might be tricky to diagnose, might be difficult to recognize the patient who's having the symptom, and sometimes, or most of the time, they don't fulfill the criteria, and it really needs high clinical suspicion for it to be diagnosed. So try today to cover, I mean, it's a really large topic, so I tried my best to summarize it. Hopefully you will get the main point, will help you with your basic day-to-day work. So let's start. When we talk about CNS infection, that includes the brain, obviously, which is cerebrum and cerebellum, spinal cord, optic nerves, and the covering membranes. And again, why it has been involved in this teaching, because it's a very important topic to talk about, as CNS infection is a medical emergency. And if not treated well, it can lead to substantial morbidity and mortality and long-term sequelae. So we'll be covering today the main CNS infection, so the big report, the division, including meningitis, encephalitis, and brain abscess. So let's start with meningitis. As we all know, meningitis is the inflammation of meninges, and meninges is covering the brain. So inflammation, meningitis is basically inflammation of the brain covering. So it's not, so the infection does not involve the brain itself, just the layers. And we'll talk about this later, and we know why this is important to recognize. And any organism can cause meningitis, ranging from bacteria, virus, fungal. Sometimes meningitis can be non-infectious, but we'll not be talking about this on today's session. And yes, meningitis is a rare infection, especially after vaccination, but it is serious infection. That's why we need to know about it. So how do we get meningitis? We can encounter the infection either from bloodborne spread, or we can get it from direct spread if we have infection nearby. And obviously by nearby, we talking about middle ear infection, or mastocytitis, or if there's fracture or any impairment or a hole that allow the bacteria or the infection to enter the brain. And it could be from colonization from an foreign body in the brain, like implant or a shunt. So how do you know this patient is having meningitis? Everybody's aware about the triad of headache, neck stiffness, and altered sensorium. But again, as I said earlier, it's not that straightforward in medical practice, and it needs a high clinical suspicion. So there'll be many slides in this presentation. I know many table. It can be crowded and messy, but some of these tables are really nice and summarize the topic. So as if this table talking about the age group that's affected by the infection and the treatment for it. And why we're dividing it this way, because some infection is common in a specific age group. That's why we use a specific medication to cover for it. So if we ignore the neonate and the infant and we start from the adult, we all know meningitis will be treated by 2-gram ceftriaxone 2 times a day. And why is that? Why is this choice? Because the common infection bacteria that cause meningitis is Streptococcus pneumoniae and Neisseria. And the other option that listed here, not commonly used, but we can add vancomycin, especially in immunocompromised patient or for a specific situation. But in general, we use ceftriaxone for treating bacterial meningitis. And you can see in elderly group, one of the options, ampicillin, has been added. And the reason is another bacteria is appearing here in the common pathogen, which is Listeria. So if you have patient more than 60 suspecting meningitis, and before receiving the culture or the sensitivity, it's better always to put him on ampicillin. And as we said, for immunocompromised, we need more coverage. And for other complicated meningitis as post-brain surgery or atypical meningitis. So I'm just talking very quickly about the 4 common bacteria that cause meningitis. Streptococcus pneumoniae is the most common bacteria associated with meningitis, and usually meningitis is a one-off, so you don't get recurrent meningitis unless this is for a specific patient and if there's a reason for it. And the most common cause of recurrence in CSF leak is Streptococcus pneumoniae. And obviously all infection increase in HIV and immunodeficient patient, and as we all know, it's common in winter and overcrowded environment as daycare. For Neisseria, as we all know, it's a gram-negative diplococci, and the infection usually counted by contact with droplet. It is the second common cause of bacterial meningitis, and the differentiation of Neisseria is finding rash in examination, which is a famous petechial rash, and that's serious because it can lead to fulminant DIC, and then it can lead to hemorrhagic necrosis of adrenal. So that's why it is it's very important to be recognized and treated. So that's the rash we just talked about. It's not very common and it's not associated with all Neisseria meningitis. Haemophilus influenzae is a gram-negative coccobacilli, and it's becoming less common, especially after the introduction of the Hep vaccine. The rest group is immunocompromised patient, for whatever reason, chronic disease or HIV. And last one, Listeria, as we said, it's mainly an infection of elder age group. In general, adult, it doesn't cause symptom except for mostly immunocompromised patient. And there have been outbreaks associated with, as we all know, Listeria associated with specific type of food as unpasteurized milk or undercooked meat or chicken. So Now, if you're suspecting this patient is having meningitis, as we said, either coming with a triad of fever, neck stiffness, altered sensorium, and a headache, and the patient is septic. How do we reach the diagnosis? Obviously, you need to investigate and do blood tests for all septic patient, but you cannot diagnose meningitis without having CSF examination. And I know it is invasive procedure, and no one like it, not the patient or the doctor, but it is a mandatory test to diagnose meningitis. So when doing lumbar puncture on a patient for diagnosis, you have to do opening pressure, and this is a tip that I'm giving to you, because most of the time for meningitis we just go for cell counts and protein and gram-10, but opening pressure is a very important part of CSF analysis. So you send for the usual glucose paired with serum, protein, white blood cell count, and gram-10, and please send viral PCR for all cases of suspected meningitis. Do we need to do brain image for meningitis patient? For diagnostic purpose, it really adds little benefit, but we usually do it to rule out other differential. And I don't think anyone would be really comfortable of doing lumbar puncture without seeing, making sure there's no contraindication and the brain is not tense. And again, we can do it looking for complication, but in case of meningitis, it's not really helpful for diagnosis. So there are specific reason for doing brain imaging according to Infectious Disease Association in America. I'm not sure this applies to UK, but in general, as I said, no one would be really comfortable of doing lumbar puncture without looking at CT head. So you need it mainly in immunocompromised patients, as we said, because there are many other differential. There's history of CNS infection, so recurrence, again, there's a suspicion. If you have a seizure, again, there's a suspicion of other differential, focal neurology, abnormal GCS, and papilledema. And these, the last two, raise the possibility of having high intracranial pressure, and this is obviously a contraindication for doing lumbar puncture. So this is another table, very helpful, although it's very basic, but helping to differentiate in general between other causes for meningitis. So as we said, we look for opening pressure, cell count, glucose, and protein. And the top row, we can see the normal values. So cell count should allow to have 5 lymphocytes. So 5 cell, and it has to be lymphocyte, cannot be anything else. Usually cell count is really high in bacterial infection, and mainly polymorph with low glucose and high protein. And again, this, as you can see, help us to differentiate between which type of meningitis. And again, you can differentiate by saying for fungal and viral, both causing lymphocyte, but CSF protein is usually elevated in fungal meningitis, but usually normal in viral meningitis. And this is not a rule, but help us to reach the diagnosis. I think that's the same table we talked about earlier. So this is telling us about the treatment, and for all adults, you treat with ceftriaxone 2 grams twice a day, and we add ampicillin for elderly patient. vancomycin can be added for immunocompromised patient, and if there is an unusual or no response for ceftriaxone. So how about dexamethasone? Do we add steroid to all patients with meningitis? So in pediatric maybe, but in adult, studies didn't show much evidence, or there's no difference in long in the outcome, except little evidence supporting decreased complication. But there's not much evidence of using it, especially in uncomplicated meningitis. And if it has to be given, it has to be given with the first or before the first dose of antibiotic. So as early as better. And the treatment we talk about covering bacterial meningitis. So what do we do with viral meningitis? So viral meningitis, usually the patient will be unwell, as in having headache and fever, but they will be less as sick clinically in bacterial cases. Sorry for the interruption. So we're talking about viral meningitis. As we said, patient will be less symptomatic with it, and the treatment usually conservative. For fungal meningitis, it's not something that we see commonly, and usually we see it with immunocompromised patient. And if the patient is immunocompromised and regarding the CSF analysis, we're suspecting fungal infection, then we have to add amphotericin. So moving to encephalitis. Why this is different? Because encephalitis is the inflammation of the brain itself. And it can be caused by all infectious agents, from viral, bacteria, or parasite. But as we all know, the famous cause for encephalitis is herpes virus. And encephalitis can be post-infectious, and that's usually happen because of reactivation of neuronal tissue. And again, the most common viruses to cause this is herpes and varicella zoster. And the famous post-infectious encephalitis or brain infection is ADEM. And we see that mainly in young adults and in children. And the last form of encephalitis is the non-infectious one. This can be caused by metabolic toxin, autoimmune, or paraneoplastic. But again, because this is Cns infection, will not be covering this part in today's session. So how does patient with encephalitis present? Because encephalitis is the infection of the brain tissue, the presentation beside the fever and sepsis depend on the area that's infected in the brain. And because we said herpes is the most common virus that causes meningitis, and herpes is famous of infecting the temporal lobe. That's why most patients with encephalitis present with temporal lobe abnormality in form of personality changes, psychosis, and hallucination. So this is terribly helpful in summarize the each viruses and the management for it, and also talking about the presentation. So the herpes, we just talk about that, causing temporal lobe abnormality, and it can cause seizure. The treatment for it is usually as acyclovir 10 milligram per kg every 8 hours. Varicella zoster is the second common cause for viral meningitis, and the treatment is the same. We have different viruses that can cause meningitis, but we don't encounter them commonly in practice, as we said, mostly in immunocompromised patients. So I know this is very small, writing and annoying diagram, but I find it very helpful in diagnosing a patient with encephalitis, especially for junior doctor in on-call setting. So if you have a patient with showing signs of encephalitis, as in altered mental state, new seizure, fever, headache, and you suspecting meningitis, then what do? We obviously send for blood test. And as we said, we cannot diagnose Cns infection without having CSF analysis. So can we do CSF? No contraindication for lumbar puncture? Then yes, we go ahead, do lumbar puncture, and send for the markers that we agreed on earlier. If we cannot do lumbar puncture because of any contraindication, then we just go and treat, as we said, with acyclovir. And the part that is not showing is if the reason is not clear for the encephalitis, then we proceed with MRI and asking for infectious disease consultant advice. So speaking of MRI, this is an MRI for a patient with encephalitis, and as we can all recognize the abnormality in the left temporal lobe. And MRI, not like in meningitis, brain imaging is very helpful and a part of diagnosing CNS infection. So again, if you're not sure about, just proceed with a scan, either CT brain or an MRI brain. And a third diagnostic approach is doing an EEG. And why we're doing EEG in some cases that's not clear, because it helps us with diagnosis, especially if you have patient that not waking up with sepsis and no clear source of infection. You can diagnose this patient is having seizures and convulsive status, and this with infection again point to a CNS source of infection. So how do we treat? Obviously, we need to give supportive management for all the patient, and the mainstay of treatment of encephalitis acyclovir, and it will go by 10 milligram per kg 3 times a day. And obviously, we lower the dose to a renal dose if there is renal impairment. The third main item for CNS infection is brain abscess. And what is brain abscess? Abscess is an abscess everywhere. So brain abscess is again localized suppurative infection in the brain parenchyma. And how does it happen? So again, the same process of abscess. There'll be focal inflammation and edema, which is early cerebritis, which later on lead to wider inflammatory response with necrotic core, which is late cerebritis, and this can be few weeks after the first, the early stage. And then later on, this would be surrounded by collagenous capsule. So what are the causes of brain abscess? How do we get the brain abscess? Usually the most common way of getting the brain infection is from spreading of infection from nearby structures, same like middle ear or chronic sinusitis or even dental abscess. The other way of getting it will be through hematogenous spread. And in the hematogenous spread, usually there will be multiple abscesses, not a single one, and usually they follow vascular distribution. So if we're talking about the main causes of brain abscesses, usually staph aureus or streptococci. And quarter of patients might have polymicro in the causation for abscess or in the culture later on. And other unusual causes for abscess can be found in immunocompromised patients. So how does patient with abscess present? Again, there is a triad of fever, headache, and focal neurology. And as I said, the classic feature doesn't have to be present in every patient. And obviously, patients are septic, so they'll come with fever, rigor, they might have seizure as well, and altered level of consciousness. So how do we diagnose abscess? In this, it's the first infection, I have to say, you need to do a CT scan or an MRI brain imaging. You cannot diagnose brain abscess clinically or by blood tests only. You need to confirm that with brain imaging. And obviously, MRI is usually superior to CT head. And how does abscess look like in a scan? It usually abscess is a ring enhancement lesion in the MRI, and surrounded will be necrotic tissue surrounded by variable zone of edema. So this is how abscess look like, and as we see, this is multiple abscesses, ring enhancing lesion in there, and how the radiologist differentiate between other cause of ring enhancement lesion by doing other sequences in the MRI brain as GRE in this case, which differentiate between other cause of the similar lesion. So again, we always need to do septic workup for all septic patient. Lumbar puncture is not really helpful and can be contraindicated in abscess patient. And even if we do it for whatever reason, CSF will show a mixture of polycytosis and high CSF protein, and the culture usually negative. So how do we treat brain abscess? It is a combined approach. We need the help of our neurosurgical colleague. We usually cover with antibiotic, broad spectrum antibiotic, but obviously we need to drain the abscess. And the best way of doing it is stereotactic needle abscess aspiration, CT guided, or whatever the surgeon decides to do. So before moving on, just remember I have a slide about contraindication for lumbar puncture. I'm not sure what happened with that, but in generally, lumbar puncture is very important for diagnosing Cns infection, and as we said, the contraindication is evidence of having decreased intracranial pressure, either through doing a CT head or clinically if patient is very low GCS. And obviously, if there is infection of the lesion of the the lesion of the lumbar puncture, or if there is any coagulopathy. So if there is any reason that will delay patient of having lumbar puncture, then you have to treat. So as we all know, the general rule, if you suspect CNS infection, if you suspect meningitis, you have to treat. And you start empirical therapy, the therapy you agreed to. And yes, therapy and starting antibiotic might reduce the result of having positive blood culture by almost 50%. But again, this is very important and for the patient's sake. So I thought about also talking about Mycobacterium infection, because mycobacteria affect the CNS in many ways. They can cause tuberculous meningitis, and we already talked about tuberculous meningitis. It can cause tuberculoma, which is again specific lesion and can behave same like abscesses, and it can infect the spine by causing destruction to the spine and called abscesses. So how do you diagnose the Mycobacterium? We go through the same rule by doing CSF examination. And as we said, we'll have high lymphocyte and low serum, low glucose and high protein. And gold standard is culture. Usually we send culture for gram stain, but if there is any suspicion of tuberculous meningitis, we should add acid fast bacilli or Zinn-Nielsen stain. And again, you treat if you suspect. And then imaging always helpful, brain or spine, depending on the presentation of in differentiating which type of infection we have. So this scan showing us multiple tuberculoma. This is the biggest one, but we can see there's multiple calcified, other smaller lesion. And this MRI shows area of involvement of spine. It's the common area, usually thoracic spine, but it can affect anywhere. There's no rule. And it's causing cold abscess as well. So how do you treat Mycobacterium meningitis or Mycobacterium infection in general? We use anti-tuberculous medication, and as Mycobacterium infection anywhere, we go for 3 agent minus 1 or plus 4th agent, and always don't forget to add steroid for Mycobacterium meningitis and pyridoxine. Is there a rule for surgical intervention? Yes, especially if there's pressure symptom or mass effect from the tuberculoma, or obviously for spine tuberculosis. The brain also might be infected by rare and uncommon organism, and this is mainly common in HIV or immunocompromised patient in general. So we can have unusual viral and fungi or even parasite infecting the brain or spinal cord. And sometimes the infection might happen because of reactivation of latent pathogen has been there nobody the whole life, and then reactivated when the immune system went down, as JC virus, Epstein-Barr virus, cytomegalovirus, and toxoplasma. You cannot talk about immunocompromised patient without mentioning IRIS. IRIS is an immune reconstitution inflammatory syndrome, and usually happen because of exaggeration of activation of the immune system in response to treatment of infection immunocompromised patient. So paradoxical worsening of infection following initiation of ART therapy in especially in HIV patient. So usually we encounter this in patient and tuberculosis, cryptococcal meningitis, or PML, which is the JC virus infection. And to avoid this, or even to treat it if it's already happened, we cover a patient with a steroid. So, as we said, the steroid can be indicated in specific situation in CNS infection. Again, another historical infection, but we cannot cover CNS infection without talking about syphilis. And syphilis is not that common since obviously this penicillin. And neurosyphilis become now an existing disease within HIV patients. So, as I said, it's mostly in an immunocompromised patient. And syphilis can infect the brain either early on or in later stage. So early neurosyphilis usually present as syphilitic meningitis, and usually it's early on, the first 12 months of infection. And the patient present similar as meningitis with headache, photophobia, and cranial nerve palsy this time. And also for syphilis is famous of infecting the eye, so plus or minus ocular uveitis. And the other way that syphilis affecting the brain is late neurosyphilis, and this usually happens very late. It might take 5 to 20 years for it to present, and it can present in 3 different ways as meningovascular syphilis, CNS gomas, and Davis dorsalis. And we're not going into detail of that because that's a whole different topic. But we just need to know that syphilis can infect the brain either at early stage or late stage. And how do you diagnose this? The usual way of diagnosing syphilis by PCR test. And if that's become non-reactive, they have the option of serum troponin test. And if again high suspicion everything is coming back negative, then you have to do a CSF VDRF. And as we all know, the treatment for it is penicillin G. Lyme disease is another unusual CNS infection caused by one of the spirogate, Borrelia burgdorferi, and they obviously the symptom the patient experienced because of body immune response to it. And Lyme have 3 stages, usually early localized, early disseminated, and chronic disseminated. The early disease is just a rash. It can be self-limiting and can just go without any infection, but the patient mostly remains seropositive. The second stage involving all body, and again, patient can respond, can resolve, the symptom can resolve without treatment, but if you don't treat the patient, the spirogate becomes sequestrated in organs, including the brain. And the third stage is arthritis. So how does Borrelia infect CNS, and what does Lyme mean? So Lyme usually, symptoms usually take more than a year for it to manifest as CNS infection. And it can cause literally everything. It can affect the brain by any means, causing speech problem, weakness, gait difficulty, ataxia. It can affect the spinal cord, can affect the visual disturbance, and mood, sleep. So if you have a patient with complicated or neurological presentation does not really be explained by one pathology, you can always search for Lyme. How do you investigate for Lyme? By, again, CSF for all CNS infection. And Lyme will be vesiculocytosis, mainly monocyte, and high protein. EEG and CT usually help us to diagnose Lyme disease. And again, because we said Lyme can cause everything, in the CT we can see multiple infarct, cerebral atrophy, and white matter abnormality in the MRI, which would be very unspecific. So again, this is need a high clinical suspicion, and sometimes you need to go back and ask the patient multiple times about a tick bite, or if they have been in areas that is endemic for Lyme disease. How do you treat Lyme? By early on by doxycycline, really, if it's diagnosed and treated early, and late we can try on ceftriaxone. Alternative will be penicillin and doxycycline, and obviously in late stages there is treatment failure reported. So, and the COVID era, we cannot mention CNS infection without talking about COVID. And although we don't have enough data, but COVID reported to affect CNS as other organ in your body, and it's mainly these are complications from COVID infection. So it can affect the brain by any means, by causing meningitis, encephalitis, Parkinsonian feature, Alzheimer, and stroke from hemorrhagic or ischemic. We've seen both cases. Demyelination can present with seizure or even psychiatric manifestation. And obviously, we all come in contact with long COVID, which is causing vague symptom, which can involve neurology as well, in form of just memory impairment, very vague symptom of numbness here and there. So COVID for sure can cause some CNS manifestation. So I guess what I need to say from this presentation is CNS infection is serious and need urgent high clinical suspicion and urgent management. And if you suspect, you just treat. If there's any delay because of no one is trained to do lumbar puncture, or we cannot do the scan, a high INR, then you just treat and then deal with that later. And you need to think about CNS infection in any septic patient with no clear source, and especially if there's abnormal neurology and examination, or let's say first seizure. But obviously, you don't just treat all delirium patient as CNS infection. So it can be sometimes tricky. And an immune compromise, you need to think wider than usual because they can have atypical bacterium, atypical infection, and vice versa. So if you see an atypical bacteria, then you need to check for HIV or check for any reason for immunocompromise. Thank you all for listening, and ready to take any question if you have.
Brilliant. Thank you so much, Jihad. Again, that was really, really good overview of what is a very, very broad topic. Even getting to some of the more, getting towards some of the more niche infections. As I have to say, coming from South Devon, syphilis is actually on the rise for various reasons in our population. I'm not sure about around London with you, Terry, but
no idea.
No, I don't know. My knowledge of the specific syphilis dynamics in my area is not sort of on point. But I'm sure Jihad, maybe have you seen any syphilis cases at all?
So yes, I was about to say from my, obviously minimum experience, really, I haven't seen any syphilis patient really. but maybe neurosyphilis per se is not that common, but I'm sure there
Yeah.
is many syphilis patient around.
That's right. I mean, if we're getting sort of smallpox-related viruses appearing
Yeah,
in the UK, maybe we're about to go through a renaissance of things like plague and syphilis as well. But
yeah.
never know. I just have one question. It might be quite technical, but in terms of diagnosing EBV in immunosuppressed people, just obviously because it's sort of a lymphotropic virus anyway, is there any way that you can tell whether it's the EBV that's the cause or whether it's a sort of bystander? Or is that probably a bit?
Well, I mean, I guess just a short answer is really I'm not sure really.
Okay. Okay. Does it tend to cause any different syndromes, or is it just like the patient seems generally unwell, like they would just because they're immunosuppressed?
You mean an HIV patient?
Yeah, or just HIV where the cause isn't necessarily the HIV itself.
Well, I mean, so in a HIV patient, if they're well covered on medication and very compliant and everything, they don't usually encounter this unless they stop the treatment or the CD4 count is really dropping very low. But so I'm thinking if you have a patient with HIV or immunocompromised, and it came in with CNS infection. So I think my message is you need to check for other unusual causes of CNS infection. If everything is becoming back, if the culture and everything coming back negative, then could it be the unusual infection as the cytomegalovirus, Epstein-Barr virus? I'm not quite sure for what exactly the specific test to confirm it, but I'm not exactly sure.
Okay.
So.
Yeah, that's all right. It's no, it's just an interest. Okay, it doesn't look like we've got any questions coming through.
Should I stop sharing or should I
put the feedback form? Oh, there we go. Yeah, you can do it via the QR code as well, guys. If we just leave that up for a minute or so,
sure.
People can either provide feedback via there's a new button in the chat which we can press. You can get a copy of the presentation. We normally try and get it out within a couple of weeks. And like Terry said at the beginning, all the recordings are normally, we had a bit of an issue with the acute stroke one, but it's resolved. But all the recordings generally go up within 72 hours. Thank you for everyone who's attended today and who's attended the last 10 or so sessions.